For this podcast, I'd like to talk about the treatment of overactive bladder. Some definitions that one needs to know is that overactive bladder is a syndrome of urinary urgency, usually accompanied by frequency and nocturia, with or without urgency, urinary incontinence, in the absence of urinary tract infection or other obvious pathology. The minimum requirements needed to make this diagnosis are a history, physical, and urinalysis. It is not required to do other testing such as cystoscopy, urodynamics, or post-void residual. Urinary urgency is the complaint of a sudden compelling desire to pass urine, which is difficult to defer. Increased urinary frequency is the complaint that micturition occurs more frequently during the waking hours than previously deemed normal by the woman. Urge urinary incontinence is the complaint of involuntary loss of urine associated with urgency. So what goes into the treatment of non-neurogenic overactive bladder? I'm going to refer back again to the American Urological Association and SUFU guideline from May 2012, and they list first line and second line treatments that I think any general provider can do. They include, to begin with, clinicians should offer behavioral therapies such as bladder training, bladder control strategies, pelvic floor muscle training, fluid management as first line therapy to all patients with OAB. Behavioral therapies may be combined with antimuscarinic therapies. Second line treatments. Clinicians could offer oral antimuscarinics including darafenicin, fesoterodine, oxybutynin, butynin, solifenacin, tolterodine, or trospium as second-line therapy. They also recommend that if an immediate release and an extended release formulation are available, then extended release formulations should be preferentially be prescribed over immediate release formulations because of lower rates of dry mouth. Transdermal oxybutynin may also be offered. If a patient experiences inadequate symptom control or unacceptable adverse drug events with one antimuscarinic medication, then a dose modification or different antimuscarinic may be tried. And I would like to point out that we have another class of medications that's come out since this guideline statement was made. It's a beta-3 agonist. Its brand name is Myrbetriq, and I think that most providers are using this much along the same ways that they would use an antimuscarinic, and especially when there's antimuscarinic side effects. If a patient experiences inadequate symptom control or unacceptable adverse drug events with one muscarinic medication, then a dose modification or different antimuscarinic medication may be tried. Clinicians should not use antimuscarinics in a patient with narrow-angle glaucoma unless approved by the treating ophthalmologist, and should use antimuscarinics with extreme caution in patients with impaired gastric emptying or a history of urinary retention. Clinicians should manage constipation and dry mouth before abandoning effective antimuscarinic therapy. Management may include bowel management, fluid management, dose modification, or alternative antimuscarinics or the beta-3 agonists, which I am adding into that statement. Clinicians must use caution in prescribing antimuscarinics in patients who are using other medications with anticholinergic properties. Clinicians should use caution in prescribing antimuscarinics in the frail OAB patient. Patients who are refractory to behavioral and medical therapy should be evaluated by an appropriate specialist if they desire additional therapy. So that's the point at which you would refer on to a urologist or a urogynecologist. So, having said all that, I think most of us would also add in that there are reversible or treatable causes of overactive bladder that we look for, and there's a very convenient, easy to remember mnemonic called diapers. D stands for delirium. I is for infection. A is for atrophy, either atrophic urethritis or vaginitis. Psychologic, especially depression, pharmacologic, especially diuretics, alpha blockers for hypertension control, antidepressants, unfortunately, can also be associated with it, and sedatives or sleeping pills, excess urine output, such as congestive heart failure, excess intake, and even hyperglycemia, restricted mobility. And very often we recommend bedside commodes to patients who complain about not making it to the bathroom in time, having urge incontinence. This really does improve the situation for a lot of patients. And finally, stool impaction. So how can one tie all this together into an algorithm? Well, the AUA guideline on non-neurogenic overactive bladder actually has an algorithm. And this is kind of a general summary. At first, take a history and physical and urinalysis. If the diagnosis is unclear, you can move on to other testing. But if you come back to a diagnosis of overactive bladder, patient education comes first, with normal urinary tract function described, benefits of treatments and risk of treatments and alternatives reviewed upon, and an agreement on treatment goals, including possibly no treatment at all. First-line treatments should be behavioral treatments and considering adding an antimuscarinic if treatment is partially effective. If treatment goals are not met with behavioral treatments, then definitely move on to antimuscarinics with active management of adverse events, and consider dose modification or alternative antimuscarinic if effective but adverse events are intolerable, or even a beta-3 agonist. If treatment goals still are not met, then at that point one should consider referral to an expert for further evaluation and treatment options, which could include sacral neuromodulation, peripheral tibial nerve stimulation, or intradetrusor Botox A.